Welcome, and I have been requested to discuss whether we should routinely use non-invasive ventilation after weaning. I will be doing this from the luxury of my kitchen, and you are most welcome here. So, just as a spoiler, I'd like to mention that the official ERS ATS clinical practice guidelines have actually discussed this topic back in 2017. But before I actually discuss what was in these guidelines, I'd like to give some background, and then after that we will mention what has happened since and moving forward. So the prevalence of weaning failure in this interesting study, which included more than 100,000 patients who received mechanical ventilation in US ICUs, was 10%. And this is probably a good reflection of what is happening in our ICUs, although earlier studies showed a 25% rate. Unsuccessful extubation has a price in terms of ICU length of stay, in terms of hospital length of stay, and in terms of mortality, both in ICU and in hospital. You can see there was a major difference in these two categories of patients. Now, this is a retrospective study, so it's very difficult to discuss causation, but there does seem to be association between reintubation and more complex weaning. So what is the price of prolonged weaning? Patients receiving prolonged mechanical ventilation account for 6% of all ventilated patients, but consume more than a third of ICU resources. And mortality increases with increasing duration of mechanical ventilation. On the other hand, weaning may also be too prolonged. And in this interesting work done by a task force way back in 2007, already the authors noted that approximately half of the time of duration of mechanical ventilation is spent on weaning, and half of self-extubations did not require reintubation. In other words, the patient was prepared, but the tube was not pulled out. Now, not much has changed since then, except for the fact that maybe we use more protocolized weaning. But we do have something to look forward to in terms of comparison of various modes of ventilation for weaning in the future. We are in between a rock and a hard place in terms of the need to extubate as soon as possible on the one hand, and avoid the need for reintubation on the other. So to assist us in this complexity, we have on the one hand CPAP or BiPAP, which are pulled under the term non-invasive ventilation or the high-flow nasal cannula. And I'm going to start with CPAP and BiPAP and discuss these first. Going back to the ERS ATS guidelines, the authors then found that for unselected patients, non-invasive ventilation provides no benefit compared with conventional oxygen therapy, and suggested that it should not be used to prevent a post-extubation respiratory failure. And again, I'm highlighting to prevent. This was a recommendation based on very low certainty of evidence. For at-risk patients, the guidelines suggested that non-invasive ventilation decreases both mortality and intubation rate, and therefore suggested that NIV used to prevent post-extubation respiratory failure in patients at high risk. With regards to treatment, the authors, and this is a verbatim cite, said that NIV use led to an increase in mortality and had no clear effect on intubation. They suggested that NIV not be used to avoid reintubation in patients with overt respiratory distress after extubation, but stated that their findings were limited by lack of participating center experience in many of the studies, by limited enrollment at some sites, and by few COPD patients that participated in these trials. Finally, the authors also studied whether NIV should be used to facilitate weaning of patients from mechanical ventilation. And here they noted that for patients with COPD, NIV decreased mortality with moderate certainty and weaning failure with low certainty by about half. And therefore they recommended that NIV be used to facilitate weaning from mechanical ventilation in patients with hypercapnic respiratory failure. And they made this a conditional recommendation because they stated that the use of NIV for weaning is more complicated than use for other indications, and therefore it was only a conditional recommendation. Specifically with regards to use of NIV for patients that are hypoxemic, they made no recommendation. And they found a special importance in stating that centers must have adequate experience to use NIV in this setting. What have we learned since? So basically, there's been this randomized control trial that was published in 2019. It was published by the NHS in the UK. It was a pragmatic, open-label, multi-center trial. 51 UKs in the UK ICUs had participated. They included patients that received mechanical ventilation for at least 48 hours and were categorized as ready to wean apart from the fact that they had failed a spontaneous breathing trial. These patients were then randomized 1-to-1 to either ongoing invasive weaning or extubation to NIV with the initial IPAP and EPAP settings based on pre-extubation settings with mechanical ventilation. Both arms had protocolized weaning, and the groups were well matched at baseline. The authors managed to collect 182 patients in each group. And having done this, they then showed no difference in the median time to liberation from ventilation, no difference in mortality at any time point. They did find more reintubations among those patients randomized to non-invasive ventilation, but on the other hand, this group had less days of mechanical ventilation overall. They required less antibiotics, and NIV was associated with a higher net cost and with a lower net cost and a higher net effect. But the most important piece of data in this trial is hidden here on this part of the graph between assessment for eligibility and randomization. And if you're looking here, patients underwent spontaneous breathing trial, but were excluded not because they had passed spontaneous breathing trial, this is this group, but for other reasons that are undeclared. And here, my assumption is that the doctor said, not in my school. We're not extubating a patient that has failed a spontaneous breathing trial. What about the high flow nasal cannula? So in 2020, we published this meta-analysis showing a comparison between the high flow nasal cannula and non-invasive ventilation. And then we showed here that there was no effect or no difference in terms of reintubation, mortality, and post-extubation respiratory failure. NIV high flow nasal cannula did have, however, some effect in terms of reduction of hospital length of stay, ICU length of stay, and patient comfort. So that did have an advantage over NIV. When comparing high flow nasal cannula to conventional oxygen therapy, we did find an advantage in terms of reintubation and also in terms of post-extubation respiratory failure, which we did not see when we compared the high flow nasal cannula to NIV. So it seems that there is an advantage compared to conventional oxygen therapy in two very strong outcome measures. Since then, there has not much been published on with such comparison, but I am going to show you a trial in a minute, and this refers to what lies ahead. So what does lie ahead? This study that was published in JAMA showed a compared high flow nasal oxygen plus NIV to high flow nasal oxygen alone. These studies included patients at a high risk of extubation failure that were elderly and had underlying chronic cardiac or lung disease, only in ICUs. The authors showed that those patients receiving high flow nasal oxygen alone were more likely to undergo reintubation compared to those that were receiving a non-invasive ventilation plus high flow nasal oxygen. This study is a new thing in the fact that it actually shows a comparison of two modalities to one. And this may be the way to go when we're looking at the following issues. First of all, who are the patients at risk? If we don't know who they are, perhaps it's wise to use more than one tool. For most included studies in the ATS guidelines, at-risk patients include those aged, say, at 65 years or older, and those with underlying cardiac or respiratory disease. But even the authors showed inconsistencies regarding risk criteria and stated that there was no data on unplanned extubations which are clearly a high-risk group. I'm using this study that had to do not with ICU patients, but actually with patients that were considered post-operative respiratory failure in order to demonstrate another issue. These authors showed, for example, that cardiothoracic surgery, there was a benefit with NIV over conventional oxygen therapy, whereas in abdominal surgery, no mortality benefit was shown. Now, why is this? Probably for one of the reasons is this little piece of data that was not given in the paper. Cardiothoracic surgery is accompanied by a relatively high risk of respiratory complications, whereas abdominal surgery has a lower risk. In other words, the greater the risk, the greater the likelihood of benefit. In this case, when we're talking about selecting populations, it's wise to know who are patients at risk in the ICU. So who is that patient at risk in the ICU? We know these are older patients, patients with cardiac or respiratory morbidities. We also know these are frail, possibly frail patients. We're assuming that patients with anatomical limitations may be patients at risk, but we have very little data on that. And there is interesting literature coming out of anesthesia showing that patients that received more opioids on the day of surgery had more postoperative respiratory failure. So how much at fault are we in terms of the drugs that we're giving our patients? Nobody's ever actually looked at that. And we've not tested blood levels of medications, sedation, and opiates in patients in the ICU before we've performed extubation. We also have not discussed yet cognitive limitations that probably put the patient at risk for respiratory failure after extubation. So how do we pool all these patients together? We need to focus on the mechanism of failure before we start saying we need to give this to everybody. The mechanism of failure can be local respiratory problems, impaired oxygenation, inefficient ventilation for a myriad of reasons, and loss of airway patency. That there can also be systemic causes for mechanisms of failure, including, as I mentioned before, obtundation, agitation, uncooperative patients, and even just depression, not to mention issues that we know with cardiovascular patients, such as tachycardia, arrhythmias, ischemia, shock, and so on and so forth. We also need to focus on specific support. We don't discuss invasive ventilation as though it was just a mix of fruits. We also shouldn't discuss non-invasive ventilation in the same way. So before we even begin to discuss whether everybody should be receiving non-invasive ventilation, we should clarify exactly what we're talking about. What interface? Should we even begin to pull these interfaces together? What devices are we using? Can we actually pool these devices together? And there is a whole lot of devices that we're using both in and out of hospital. Are they even comparable? Outcomes in relation to non-invasive ventilation are a function of the patient's underlying problem, but also of patient device interface, device settings, and device characteristics. All of these affect outcome. So we need to be thinking of different treatment modalities for different treatment targets. Patients that are more obese may have more atelectasis. Patients with more opiates or more drugs may have a resetting of their CO2 trigger for ventilation. Elderly, frail patients may have respiratory muscle weakness, and some patients may require increased work of breathing. When we take these considerations when we begin to think this way, we will then understand that the question should not be, should we routinely use non-invasive ventilation after weaning? The answer to that is clearly no. But in certain patients, in certain circumstances, we probably should. Thank you.